Guidelines recommend intensive statin therapy after hospitalization for CHD events. How are we doing? Well, in the February 3rd, 2015 issue of JACC, a look at underutilization of high-intensity statin therapy following hospitalization for CHD. And I'm with Robert S. Rosenson, MD, Professor of Medicine and Cardiology at the Icahn School of Medicine at Mount Sinai in New York. This is a sizable study. Let's start at the beginning. Why did you do this analysis?
We felt that it was important to evaluate whether physicians who are treating the highest risk individuals, those hospitalized for myocardial infarction, unstable angina, or so unstable they have to have the bypass surgery during that hospitalization, are utilizing evidence-based therapy. And evidence-based therapy is high-intensity statin. And the majority of the data is with atorvastatin 80 milligram daily.
So what did you find?
We were very disappointed to find that most of the individuals are coming into the hospital on low or moderate dose statins. Very few are on high intensity statins. But what's even more disappointing is that the therapy is not getting changed when they're in the hospital, when this is a very clear-cut indication, a mandate, by quality care organizations.
Now, how many people were involved in this analysis?
This was a 5% sample of the Medicare population.
So we're talking probably six figures in terms of the numbers of people.
Yes.
And what I thought was interesting is that if they come in on high-intensity statin, the odds were really high they would leave on high-intensity statin.
Yes.
So whatever they came in on is what they left with.
Absolutely.
And if they came in wrong with mild, or not necessarily wrong, but once now they've had an event, it's certainly going to be wrong, nothing gets changed.
Yeah, only in 12% of the individuals was there a shift from a low to moderate intensity statin to a high intensity statin, despite the evidence. And we wonder, why is there complacency? Are the physicians focusing on LDL cholesterol, the biomarker, and not on the evidence that supports the use of high intensity statins as being better than low intensity statins for reducing cardiovascular outcomes in this very high risk population? The message is getting confused. And I think that our study is so important because it really endorses the major change in the American College of Cardiology, American Heart Association cholesterol guidelines, is that you follow the evidence first and foremost. And then when the evidence doesn't provide the answer, then you can individualize, based on your opinion. But we really need to step back and say, boy, we have a lot to accomplish in these very high-risk individuals.
I mean, there was a lot of controversy when the new guidelines came out. Do you think some of that is people are just waiting until there's some more guidance because this was very controversial? But high-intensity statin therapy after ACS, that's not very controversial, is it? The evidence is there.
Yeah, clearly there's a major paradigm shift in the new cholesterol guidelines, and I think that there's utility for measuring LDL cholesterol in many individuals who may be on high-intensity statins and far away from their at least previous target. But exactly as you say, the population that we studied is not one in dispute. We've got two ACS studies, and then we have a study of 10,000 stable patients, the TNT trial, that clearly support its high-intensity statins where you get the greatest benefit in terms of reducing future cardiovascular events. And this is why the paper is so timely, because it supports the need for evidence-based medicine. Even though somebody may come in with an LDL cholesterol under 100 or maybe under 70, they may not get the full benefit that a high-intensity statin can provide with regards to plaque stabilization, reducing inflammation, or perhaps reducing excess number of LDL particles that are not recognized during the acute phase response.
And we also know from the data that it is best to get them on a high-intensity statin before they are discharged. Absolutely.
Providing evidence-based therapy in the hospital, allowing the patient and their family to understand why they're on this group of medications, what is the potential meaning today, what the potential impact is for tomorrow, is critical. And only when you get this buy-in, this understanding, are you going to have a favorable impact on long-term adherence to the evidence-based treatment.
So don't assume that the follow-up therapy that they're going to get from their regular practitioner is going to be what's going to give them the new prescription. Make sure they're on it before they're out of the hospital.
Absolutely, and I think that once somebody's on a therapy and there's a justification, they're more likely to stay on the therapy. The question is, how are we going to get the physicians who are taking care of the hospitalized patients to do more of the right thing?
Well, it is kind of disappointing, but it is kind of funny to look at your data to show that what they come into the hospital with is usually what they're leaving with, even when that's not necessarily the thing.
Well, we have to address these issues of complacency. In our study, we didn't have the opportunity to look whether it was the on-trial LDL cholesterol that influenced them. Is it an issue of a primary care physician, administering the medication, and maybe the cardiologist doesn't want to make a change? Well, that would be disappointing, because those of us who are taking care of the most acutely ill individuals want to do the most for them during this very vulnerable time.
You can't fix something until you know it's broken.
Yes.
Now we know it's broken. February 3rd issue of JACC is where this is scheduled for, 2015, and it is Rosenson et al. And underutilization of high-intensity statin therapy following hospitalization for CHD. For CardioSource World News, I'm Executive Editor Rick McGuire.